This video will provide a brief history and introduction to the post-acute care settings where occupational therapists work. Before we go into post-acute care, let's review what acute care is first of all, just to make sure. Put simply, acute care for OT is during an inpatient hospital stay. So after a patient becomes admitted to the hospital, they receive acute care. Note that not all patients who are in the hospital receive occupational therapy services, right? If a physician writes an order for occupational therapy services, then they would receive OT under this acute care setting. One setting that patients can go after they discharge to after this acute care in the hospital is home. But this is not always the case due to, for example, medical conditions, both mentally and physically. So let's review how post-acute care settings came to be in the United States. And learning about this brief history, I'll try to make it brief anyways, is important as it helps you, the occupational therapy practitioner, whether you're an occupational therapist or occupational therapy assistant, or actually this applies to any therapist out there too. Physical therapists, speech language pathologists, right? You guys all work, we all collaborate in these settings, so it'll be relevant to you. And it'll help you because you'll be more knowledgeable about the US healthcare system where you work. And its major player, Medicare, in the social societal impacts it has on the patients and the community. I'll talk about that also. Last, I'll go over each setting so that when you graduate and you're like looking for jobs, or like later when you switch settings in your career, you'll have a kind of general idea of each setting. And it's also important to understand post-acute care settings for discharge planning as a practitioner, whether you're an OT or not, in acute care as well, because you have to know about these settings in which you're discharging patients to and making recommendations for these other settings. So having an idea of this and appreciation for these settings can be very helpful and beneficial for your job. I'm Jeff, the OT dude, and let's get functional. Overall, post-acute care was developed for many reasons, but one of them was to reduce the length of acute care hospitalization and the medical costs overall. And a large player and payer in the United States is Medicare and Medicaid. And this began in the US in 1965, so it's actually not that long ago. Patients with similar conditions were classified and grouped into what's called DRGs, or diagnostic related groups, to better control hospital costs. And one side effect of this was that hospitals were really encouraged to reduce their costs, right? And so reducing also their length of stays for the patients that stayed at the hospital. So then patients were discharged kind of prematurely. To help with this, the US promoted subacute care settings in the 1980s, also not that long ago, to meet the patient's needs for care after discharge, as well as to reduce the medical expenditures. And the 1997 Balanced Budget Act expanded these post-acute services covered by organizations, entities such as Medicare, to the types of settings that we have today: skilled nursing facilities, home health agencies, inpatient rehab facilities, and long-term care hospitals. While this act did not specifically mention hospice care, it was included in the provisions that affected the reimbursement and payment policies for hospice services under Medicare. Now let's start with our first setting: inpatient rehabilitation facilities, or IRFs. Technically, IRFs are not considered acute care. Although IRFs may be physically attached to the hospital, IRFs are sometimes also called acute rehabilitation units, or ARU for short. The name is kind of confusing as they both have acute in it, acute care and acute rehab, but they are different settings. Acute care is different from acute rehabilitation, also known as IRFs, right? Patients actually need to be admitted to IRFs from acute care. According to data for IRFs, starting from the most common to the least common, conditions include things like stroke, other neurological conditions, debility, brain injury, lower extremity fractures, other orthopedic conditions, cardiac conditions, spinal cord injury, joint replacement, and then least common are other conditions that don't fall under these other conditions. Overall, the goal of IRFs, with R being rehabilitation, is in the name to provide rehabilitation to patients. There are nurses and other staff on site as well, part of the hospital, right? As you can imagine, so there are nice things to have that can have access to services for patients like x-rays, imaging, respiratory therapy, and other services like lab draws and getting results back really, really quickly. One thing that is also unique to IRFs is the intensity of the rehab. Patients need to be able to tolerate 3 hours of rehab a day, such as PT, OT, or speech and language pathology for their disability and functional impairments of those conditions I just mentioned earlier. And the length of stay varies, really. It depends on things like insurance, but on average, it can be 12 days. Ideally, patients would go home from IRFs, but there have been cases such as where I've worked on my caseload, where they have actually gone from the IRF to something like a skilled nursing facility, or SNF for short. This is, of course, not ideal, as if they're going to go to a SNF anyways, well, then it would be better if they went straight from acute care to a SNF instead of going into acute care and then IRF and then SNF. But patients sometimes just don't show the progress, and they aren't safe to go home either, so they kind of go into the SNF setting to get better and recover. Remember that Medicare can pay for IRFs as well as the other post-acute care settings that we'll cover in this video. So I won't mention it for each setting, but just keep that in mind, as well as Medicaid too. They're also a payer for these services. Next setting are skilled nursing facilities, SNFs, and they were established with nursing homes, and it provides an integrated service to patients. So think about the term, right? Skilled nursing facility. As the name implies, then there are nurses staffed at SNFs, as well as other support staff as well, such as like CNAs. SNFs also have PT, OT, and speech. And just as patients are admitted to the IRFs, patients must be admitted to SNFs and then go through kind of like a process to meet the insurance and medical necessity to be a patient or resident at a SNF. Since SNFs are not part of the hospital though, there are some services that come with the hospital that aren't necessarily there at a SNF, right? So there aren't things like emergency room, imaging departments, and other ancillary staff. So if a patient had like a true medical emergency, they would need to go to the emergency room and leave that SNF. And then they would probably be admitted back. It depends on the discharge at that point. Then at the hospital, they can actually go anywhere depending on, they can even go home depending on how they do, right? So there is no kind of set kind of thing. It depends on kind of case by case basis and the progression and how patients may improve at that certain point, right? Or they can go downhill and need something like hospice services too, right? So depends. The services that are provided though by SNFs include things like physician rounds, rehabilitation, like I mentioned, right? OT, nutrition care, medications, and nursing care, like for wound treatment. Each SNF is actually different, and some have pretty cool amenities. Like some have even like an on-site hair salon so that patients would not have to leave the facility. Medicare coverage for SNF through Medicare Part A can cover a stay up to 100 days, but this of course depends on things like medical necessity, and patients, they start paying on day 21, like out of their own pocket, up to day 100 via co-insurance. After day 100, the patient would technically be responsible for the cost of the SNF unless they have secondary insurance coverage. And a myth about SNFs is that patients, right, they think that they stay there and like forever until like the day that they die. But this is not necessarily true. Some even discharge in as little as a few days. Again, each patient in their case differs, right? And depends on the discharge plan going forward, like at a SNF, like the discharge plan may improve at a SNF. And then, for example, then the patient may get home health services or not need any services at all. And a term to be familiar for home health is homebound. So let's talk about that now. What is homebound? Well, according to Medicare and like their kind of lingo, a beneficiary who is homebound would, one, require considerable amount of effort to leave their home, and two, absences from the home are kind of infrequent or short duration. For example, to like go to church or for a medical appointment or something, exceptions. And the patient is restricted to their home overall, but they're considered to be they're like at home for the majority of the time. This of course could change, right? Such as an improvement in condition, so it can go up improvement or down, depends on each patient and their unique prognosis. And so patients who receive home health must also receive a physician's order to initiate this service. They can receive also services like the other settings such as nursing, PT, OT, and speech. And one thing to note is that is relatively new for OTs is that OTs can now initiate the start of care, or SOC, for home health. But the patient must also at a minimum have either PT and or SLP speech as a co-occurring therapy. So what this means is that other services such as PT and SLP or nursing can drop off in terms of services later on, and OT can be the sole therapy at that point. But in the very beginning, PT or SLP and or must be needed to initiate services. And the OT can start the documentation for things like OASIS. And the home health kind of setting is pretty self-explanatory. Most of you probably have a good idea of what it is based on the name, so I won't go into it too much in detail for this video, but it's a really great setting for OTs because, well, we work with patients in their most natural environment that is familiar with them for things like cognition and like memory problems. And it's also a comfortable setting for them. And we don't have to like deal with distractions like other staff coming in and other like interruptions like bed alarms and things like that. And the fourth post-acute care setting that we'll cover is long-term care hospital, or LTCH for short. And one way to remember and to kind of distinguish LTCH from SNFs is that patients typically require a higher level of care for LTCH than for a SNF. Examples of things include needing things like ventilator support, complex wound care, and other specialist care, just like in the name it infers, for an extended period of time. Examples of conditions for LTCH include things like complex respiratory conditions like COPD, traumatic brain injury, TBIs, spinal cord injury, degenerative neurological conditions, complex cardiac conditions, wound care like the more complicated cases, and infectious diseases, which can co-occur with the other comorbidity, I don't know how you say that, with the other conditions too, right? And the nursing ratio also, you should know, is different for LTCH, with nurses having fewer patients in their case than for a SNF due to a higher acuity at an LTCH, right? And in this setting, they also have more specialized equipment available and trained staff to provide a higher level of care to patients for their more complex needs. And patients, just like in the other settings, can receive rehab like PT, OT, and that kind of thing in this setting as well. And in terms of the stays, LTCH stays are generally covered up to 90 days. However, additional days can be covered up to a total of 150 if the patient meets certain criteria. And then beyond that, patients can be extended past this 150 days through an exception and like additional documentation and review. So can be long-term as well, just like the name says. And one setting that is also considered post-acute care is hospice. And according to the AOTA, OT practitioners play a really important role in the setting on palliative and hospice care teams. Hospice is kind of like beyond the scope of this video, but if you're interested, I also have a very cool blog post that describes the value that OT can bring to this setting. So one question that comes up is, well, what happens if a patient is like readmitted, such as back to the hospital or back to a SNF? Well, in terms of hospitals, there is this hospital readmission reduction program in which hospitals may actually be penalized for readmission for the same or like related condition within 30 days of like discharge. And the patient can like still go, right? It's like illegal to turn a patient away. But as a whole, the hospital may be like penalized because of like this condition. For a SNF, if a patient were to be like readmitted to the SNF again within like 60 days, it may be considered the same benefit period and then count towards that beneficiary's 100-day limit. These are just kind of like some examples. And of course, there are like many rules and exceptions and like things may actually change over time. So to learn more about this, I definitely recommend that you refer to the original source, the CMS website, for more up-to-date information. And also, Medicaid can provide coverage for these settings as well, right? Medicaid, not Medicare. So this can be a primary insurance source for like people who are younger, patients who are younger, or it could be a secondary source as well. So in cases with Medicare and Medicaid coverage. And one thing to note that I'm not going to go into this video is that each state has their own kind of like policies and rules and stuff for Medicaid. So coverage can really vary, and that's kind of beyond the scope of this video as well. So in summary, you learned about some common settings that occupational therapy practitioners can work in. Acute care, which is in the hospital, like for the traditional way you think about in the hospital for inpatient, as well as other post-acute settings, inpatient rehab, skilled nursing facility, home health and their agencies, long-term care hospitals, and also hospice. So I hope this helps to explain some of the unique strengths and differences of each setting and kind of introduce you to it. In the future videos, I'll go over into each specific setting and like the real like detail and like especially about the OT interventions and what it's really like. So if you found it helpful, give this video a thumbs up. I can't even speak. Give it a thumbs up and like it and all that good stuff. And I really appreciate you guys all for your continued support on this channel, as well as the OT content that is on the website and everywhere, like, I don't know, social media and stuff like that. So thanks for watching and have a nice day.